for the kind introduction. I was just talking with Emma that students will either, the next few students that defend will either like really thank me for having set up this process where you have to actually present to your peers and friends and family, or they'll really hate me. So either way. Here's what I'm doing it. Also, we're on camera, we're being videotaped right now, and it will appear, I think, after we're done, it automatically is uploaded. So, as a warning, if you ask me any really tough questions, we'll get to revisit it, my awkward answers over and over again on the web. So. I am talking today about my master's thesis, which I defended this past Thursday in Kampala. It's not this past Thursday, the Thursday before. I just got back from Kampala on this past Friday night. And there's a few pictures which are a little hard to make out at the top. But this one here in the middle is a bit dark, but I'm sitting right there in the middle, having just defended my thesis, and that's John Bartlett. There, thank you. And David Toole. So John Bartlett, the Director of Research here at the Global Health Institute. David Toole, the Associate Dean at the Divinity School here at Duke. And then this computer, Will Mitchell at the Business School has joined us via Skype in Kampala. And he's actually on the audio feed there on that laptop. So that's directly after finishing my thesis. But today I'm going to be talking about investing in people, health system strengthening, through education. It has a couple of different parts to it, and before I started, I wanted to show you what I had done during my master's work over the last 2 years here at the Global Health Institute. And can you all see okay with the light on?
I think it's better off.
I'm fine with it off too. That's great. But my master's work really started with coursework here at the Duke Global Health Institute here in Durham, North Carolina. It took the core courses, research methods, but then also importantly took classes in the business school and in the School of Public Policy as well. And that was with an eye to prepare myself for an internship that I did at the World Health Organization over this past summer in the Human Resources for Health's Health Education Department. And so that was really work on an international policy level. And that is also then paired with some field work that I did in Kampala, Uganda, and also Fort Portal in the west. And I'll show you a map of where Kampala and Fort Portal both are. And that was, my master's work was on program monitoring and evaluation. So while the internship work was an international policy project, the field work was really national and district level intervention evaluation. But as you can see here, they're all interrelated and connected. And I'll try to draw those lines for you. At the core of my work here at the Institute has been around how to improve, many of our work is around, is how to improve people's health. And to do that, what I've been working on is how to improve health systems. And to improve health systems, you really need to have better healthcare organizations. That's one way to get at better health systems. And at the core of good organizations, and you could really take out the words healthcare, but the core of good organizations are the people that make up those organizations. And so all of my work here at the Global Health Institute has been around how to improve the quality and numbers of health workers that we have working on health systems, particularly in low and middle income countries, and then even more focused on sub-Saharan Africa. So health workers, well-trained, well-compensated, well-organized health workers are at the center of good healthcare organizations and are also at the center of good health systems. So moving right along, we've done the introduction. There's really only two more parts that I want to talk about. The first is the international policy work around educating a new generation of healthcare workers and reforming health education systems to more carefully align with health systems. The second related piece is what I worked on in Uganda around health management capacity and improving the management of health systems, also through education. And then there's a fourth part of my thesis. This parts 1, 2, 3, and 4 follow what I wrote about in my thesis. Part 4 was really a very practical teaching manual for health systems strengthening through management and leadership in Uganda. So it's not a research piece, and hopefully it's actually the piece of my thesis that will be most used after it's published. And I'm not going to be talking about that today, but I'm happy to share that work with you. It's not published yet, but we're still working on it with our Uganda-based partners. So I'm going to start with laying a little bit of background work for my time at the WHO, and I'm going to start with what we know. Hey, Dorothy. Countries around the world, but particularly in Southeast Asia and Sub-Saharan Africa, have a critical shortage of healthcare workers. This graph shows us health service providers, particularly doctors, nurses, and midwives. And really, it's divided countries on a national level into two categories. Either the countries in red have a critical shortage of health service providers, and the countries in orange are countries without a critical shortage. It's not quite this black and white. This was based on a somewhat arbitrary, not completely arbitrary, but a cutoff point. But you can see that the need is really focused here in Sub-Saharan Africa, and then again a little bit in Southeast Asia. So to give some perspective on this, if you took the African continent as a whole, in 2007 we've estimated that we have roughly 0.22 doctors per 1,000 people in Africa. Okay, so here in Durham, by comparison, we have 6.7 doctors per 1,000 people. So we have 30 times the number of doctors here in Durham per person than we do. Hey, how's it going? Come on in. We have 30 times the number of doctors per person here in Durham than you might find in Sub-Saharan Africa. But that's not even really a fair comparison, because really what you need to look at is the burden of disease in Sub-Saharan Africa versus the burden of disease that we have here in Durham. And so 24%, and we're getting to very rough estimates, but about 24% of the burden of disease around the world is concentrated in Africa, but they have only 3% of the health workforce. So the disparity is extreme. There's not enough doctors. Let me give you another way to think about health workers. So if you were to take all the health workers in one country and sort of consider them to be in a bucket, which is, we'll call this middle area, that's when they're active within the health workforce. And then the bucket is slowly filling because you have health workers that are entering the health workforce through coming out of schools. They may be recruited from other countries, and then there's some planning that may happen through the Ministry of at the Ministry of Education level. So those are people that are entering the health workforce. And then there's also people that are leaving the health workforce. There's some that are leaving through retirement at a normal age, and that's just expected. But then there are a whole lot of other areas that reasons for health workers to leave the health workforce early, through migration, through choosing an alternative career. For example, a doctor may graduate from medical school and decide that being a mechanic is more lucrative than working in the, and it's very true. In fact, there have been some estimates in Tanzania that they may be losing as many as 30% of their new graduates from health education institutions who are deciding to pursue other non-health careers. So they're staying in the country but are pursuing small business or going into a completely non-health related career. Another interesting exit point is health and safety, and really mortality. And I think it's not highlighted enough in this particular diagram, but in a survey of 13 African countries found that they were losing, some of these countries were losing as many as 2% of their healthcare workers per year due to death. So healthcare workers, because of HIV, because of some safety issues on the job, were dying and leaving the health workforce. So I'm going to actually present, I think those are two great background pieces, but I'm going to present yet another problem with the health workforce. And it's a problem that's not as well articulated as what I've described to you in the previous two slides. And that is that there's a fundamental misalignment between national health education programs and national health systems. And even worse, perhaps, is that there's a misalignment between national health systems and population health needs. So what I'm saying here is that you can increase the number of healthcare workers that are graduating as much as you want, but if you don't more carefully align the national health education system with the health system, you're going to continue to have these high rates of attrition and continue to have health systems that aren't adequately supporting the population health needs. So this is a pretty abstract concept, and to kind of bring it home for us here in the U.S., this U.S. example is our aging population. So we have a population in the U.S. that's quickly growing older, and we have a health system, maybe not a national health system, we don't like to think in those terms, but a health system that may not adequately be able to respond, may not have enough geriatricians, may not have done the background research that we need to properly care for our aging population. What's even worse than that, or more dire, is that we may not be producing graduates from our schools that are adequately prepared to address the health needs of our aging population. To bring that into an African context becomes a little bit more complicated because of the huge differences between countries within Africa. But one example is the lack of health management training in Africa in general. And that, to follow that backwards through this chain, that may mean that national health education systems in Africa are focused on producing more doctors, midwives, nurses, but they may be ignoring the critical component of health management, which means you may be able to ramp up and scale up the number of health workers, but if they're not adequately managed at the health system level by knowledgeable, competent managers, then the health system still won't be able to address population health needs. So it's a complicated concept, but I think it's a very important one. And I also meant to say this at the beginning, but want to encourage you to stop me and ask questions if I'm not explaining something well, or if you just want to probe deeper on any of these points. Please, it's still very much a work in progress. What I'm going to be focusing on today is this gap here between national health education and the national health system, this supply and demand mismatch. So what I'm arguing is that we don't just need more of the same types of healthcare workers from health education institutions in low and middle income countries, but we actually need a scale up of transformative education. And so what that means that so the process has been that we looked around the globe and convened a number of meetings at the World Health Organization and found examples in countries of success, of people who had looked at what they had, who had made changes either at the institutional level or at the national level in the way that they were producing graduates from their health education systems. And when we found examples of success that occurred in multiple countries, we started to gather those suggestions together to help inform future research. So that's a set of global recommendations. And then the other piece is this transformative education, which really gets at local social accountability. So while global excellence is important for a country, for a medical school, for example, in Uganda, we're trying to emphasize the importance of local social accountability so that health education institutions can more carefully align with community and population health needs. So I'm not going to take you through each of the innovations that I recommend in this policy piece that I wrote with collaborators at the WHO, but I want to give you some examples of innovations that can happen within health education institutions. It's nothing they're all things that you might be familiar with. So, for example, reorienting curricula within institutions towards local population health needs. Another area that has shown a lot of success has been faculty development and retention, particularly in areas that, again, are needed in Uganda or in Tanzania or in Australia, for example. Numbers 3 and 4 here, rural recruitment. So the recruitment of students from underserved areas is an important innovation because those students are more likely to return to underserved areas to practice as health workers. And then also where you place your training sites. Training sites largely tend to be located in cities far away from areas that are really in need of healthcare workers. And so decentralizing those training sites and placing them in areas where more health workers are needed is another key innovation. And then this catch-all, this alignment between health and education is another important piece, so that in an African context, ministries of education need to be coordinated with ministries of health and need to be planning together for the health workforce. A great example of this is in Zambia, the Ministry of Health did a study which showed that if a $52 million investment in health infrastructure, so building new buildings, new dorms, in their medical schools, could mean that they would double the number of doctors who are graduating from their medical schools in Zambia. And so they coordinated with the Ministry of Health to make that transfer, to make that investment, along with the Ministry of Education, and improve the infrastructure. So based on those recommendations, I wanted to give you a sort of a global picture about what's going on in this area. I was working on this stream, this sort of upstream work, the normative work with the World Health Organization as a PEPFAR-funded project. And now they're undergoing a comprehensive literature review that is categorizing innovations that are found around the world into some of these same innovative categories, and looking for more. This will produce a set of guidelines that other countries can then use for implementation. And then along those lines, in implementation, the National Institutes of Health is funding two huge projects. The Medical Education Partnership Initiative and the Nursing Education Partnership Initiative. And Duke, along with KCMC in Kenya, won one of these MEPI awards. But they've put National Institutes of Health has put in $130 million into a number of MEPI projects in sub-Saharan Africa, all with the goal of training 140,000 new healthcare workers in sub-Saharan Africa. Two other streams of work that are happening. This actually just came out last week. The Global Consensus for Social Accountability of Medical Schools was a consensus document that 130 medical schools around the world signed on to. I just saw it actually on Wednesday, of not last week, but the week before, when I defended my thesis. It's really exciting. It had a lot of the same innovations and sort of principles that I talked about in this first part. And then the Lancet Commission came out in December 4, 2010, which talked about transforming health education to strengthen health systems. And this piece in particular, this transforming education to strengthen health systems, carries forward into the work that we are now doing in Uganda. So now I'm going to move from this international policy framework down to a national and then hopefully a district level. To do that, I'm going to take one small step back and talk about health systems in general. And health systems have a number of goals and outcomes, and generally they can be categorized, to improve health, to improve the responsiveness of the health system, to provide social and financial risk protection to people, to citizens or to people that live within the country, and then also improved efficiency. And the way to get there by improving several dimensions of the health system. But when you actually look on the ground at how you make these things happen, there are a number of sort of buckets or building blocks that you can use. Leadership and governance is named as one of these sort of principal building blocks of health systems. But I also wanted to point out that the health workforce is here. And so what I've been talking about has been improving the health workforce at an international level. And now I'm going to transition to talking about how you improve management of all these functions, including leadership and governance on a national and then a district level as well, particularly in Uganda. And Uganda's in East Africa. It's a landlocked country. It historically has not had very good neighbors. It's in a bad neighborhood here. It's bordered to the north by Sudan and to the west by the Democratic Republic of the Congo. This is the capital city here, Kampala. It's on Lake Victoria. And I also wanted to point out, everyone, when talking about the size of Uganda, the reference I've seen most often is that Uganda is about the size of the state of Oregon. Okay, just to give you a little bit of size context there. The district that we are working in is Fort Portal. It's hard to read. It's a town right here near the border of the Democratic Republic of Congo, next to the Ruwenzori mountain range, the highest mountain range in Africa. And it's about 300 kilometers between Fort Portal and Kampala, just to give you some example of scale there. Let's talk about the health system in Uganda, just a little bit more background. There are two major faith-based organizations that provide a lot of health care in Uganda, maybe as much as 40%. One of those is UPMB, so the Uganda Protestant Medical Bureau, and the other is the Uganda Catholic Medical Bureau. Those have been in Uganda for a long time, since really the colonial era there, and continue to be pillars of the healthcare system. Now, on top of that, there's layered a Ministry of Health, which has a number of hierarchical layers, but which has incorporated the Catholic and Protestant medical bureaus into the Ministry of Health. So they work Ministry of Health has essentially filled in some of the gaps that were there from the Catholic and Protestant medical bureaus and filled around them. They don't work in isolation, though, so the Ministry of Health actually provides some funding to the Catholic and Protestant medical bureaus. So they're all part of one health system, working together, even though there's a mix of private, what we consider private or not-for-profit providers, and public providers. But that goes all the way through the health system, all the way from hospitals down to very small clinics. They either belong to the Ministry of Health or they belong to one of the private providers. And I just put this screen here to show you that there are a number of layers and that the medical bureaus cut across a number of those layers. The layers are, it's actually a very carefully planned system. At the top you have the Ministry of Health, of course, and then a national referral hospital. I think there's 2 of them, with huge catchment populations that are like what we find here at Duke, although not with all the highly subspecializations, but a very big regional, national referral hospital. Below that, you have a number of regional referral hospitals that cover, a few districts. Below that, you have a general hospital, which has a catchment population that varies a lot, from 100,000 to 1 million. But you certainly have lab and x-ray facilities at the general hospitals. And then you have a number of levels of health centers. So you have health center 4s, 3s, and 2s that are each operated at a sub-district level. And health center 4 is what we would call like a small rural hospital. So the ability generally for someone to stay overnight there and sleep at the hospital, and would also have an operating room. Doctors operate at the health center 4 level in general. A health center 4 will probably have either 1 or 2 doctors. Health center 3s and 2s wouldn't have a doctor. They'd be staffed by a medical officer with, or by a nurse. And then a health center 1 doesn't actually have any facilities. It's a village health team. So it's a group of people from the village that kind of focus on health and give some advice and input into the health system. I don't know if you can see this or not. This is a picture of the district health office in the Cabarole district in Fort Portal. This gives you an idea. So this is district headquarters for the health system in Uganda. So this kind of gives you an idea. I don't unfortunately have a good photo of a lower level health center. But you can imagine this is sitting at the district level. So this is sitting actually above the general, right here in this scale. The district health office manages the general hospital and all the health centers below it. And that brings up another important point here, which is that not only do these health centers have catchment populations that they provide health care for, but they also manage all the other health centers below them in the chain. So it's a management structure as much as it is a patient population sort of management system. So Duke's involvement in Uganda, initially there was an initial assessment at national level, which involved 37 interviews in June of 2009. There were a number of conclusions that came out of this series of interviews that we did, but it's important to know that we came to Uganda, a partnership between the Divinity School, the business school here at Duke, and the Global Health Institute, came to the Ugandan health system with very open arms and said, please tell us what you think we could bring to you as an organization and how we can help improve the health system here. It was a unique situation for us to be in. We had a private funder that was sort of amenable to that kind of approach to a project, which I think is rare. And what came out of that, what was asked for out of those interviews was improvements in management skills in Uganda, ongoing mentorship following management training, community empowerment, and then emphasize the role of faith-based institutions in providing health care. So these leaders of the national health system said, the faith-based institutions in Uganda are onto something. They're doing something right, and we need to learn from them in the public system, figure out what they're doing well. They also said that if we did anything at all, we needed to engage at multiple levels. So it wasn't enough to sit in Kampala at the top and say, let's put beautiful plans down on paper to improve management and leadership in Uganda. They said, please, you need to work down to the district level and the sub-district level if you're going to make a difference here in Uganda. So I just want to tie this back into the work I was doing at the WHO. I mean, when I looked at this initial assessment for the first time, I actually came onto the project after this assessment was completed, but when I looked at it for the first time, it immediately reminded me of the work that I was doing at the WHO. Each of these bullet points speaks to the gap between, for example, the National Health Management Education System and the National Health System and their misalignment. So what did we do from there? Duke got together, developed an interesting partnership from these interviews. And I've kind of boxed them into categories so you could understand who the different players were at the table. But one group were really managing the healthcare. So we've got the Protestant Medical Bureau and the Catholic Medical Bureau, and then the Ministry of Health. Okay, so that's one group of 3 organizations we brought together. The other were management educators. So the 3 leading universities in Uganda in management education all sent pretty high-level representatives to this partnership. And our theory was, in getting together management educators, which are supplying health managers into the health system, and healthcare managers, which were demanding health managers and demanding the right kinds, with a little bit of help from the 3 different schools or partners at Duke, we could maybe be a catalyst for improvement. And I say improvement in general because I'm talking about improvement in the education sector as well as in the healthcare provision sector. So this is sort of our hypothesis, is that if we get these 2 groups together and let them really run the show, and we provide what support we can, hopefully we'll start to see some improvement in the health sector and the education sector in Uganda. The partnership formed in late 2009 and set these 3 goals, which I'll revisit later, but basically they were to improve leadership and management capacity in the health sector, to improve partnerships between public and really faith-based health facilities, and then to improve what they were calling the participatory interface between the health sector and local communities, but really it was about getting local communities to better inform what was happening in the health system. The partnership's activities started out, and so this is after the initial round of interviews that happened. They wanted to do a national literature review in Uganda, and then get immediately down to the district level and do a needs assessment in one particular district as to what was needed in leadership and management, and then to provide an intervention. So they wanted to run a workshop at the district level and then give ongoing project-based mentoring. So I wanted to take a step back and give you a little bit of timeline of how this all fit together. There was an initial Rockefeller funded Duke International Assessment, which had some themes that we're still carrying forward through this process. And then I've described to you this initial national level interviews in which we decided to form the partnership. The partnership forms about right here. And then from there, we go through a national level literature review of a number of sources talking about management and leadership capacity in Uganda. And then we get down to the district level and do a series of interviews to identify what gaps may be happening specifically at the district. And then we provide an intervention here, which is the workshop and mentoring pilot project. I'm not going to talk about the literature review or the interviews. I'm going to skip right to the meat of this workshop and mentoring project. So based on those first 2 activities that the partnership did, we decided to hold this workshop. And the workshop was going to be innovative in several ways. Based on our learning from those sort of the formative research that we went through for those first 2 steps. One was that we were going to combine content and context experts, and that doesn't mean that. What that means is we're going to have content experts that come from the national universities in Uganda, and they're there to provide this workshop training. And we decided to pair those content experts with local managers that knew the context of the district and knew what was going on the ground level, could bring up examples of management challenges that they were having. The session format was really around active, engaged learning processes that we're more familiar with here in the US, but which are still coming online in Uganda versus the sort of a more didactic lecture style. And then we decided that one of the keys of this workshop was to carry forward the supply and demand side partnerships that we had formed with health education and with management systems. And then the material format that we used was modular flexibility. So we developed 5 separate modules that could be taken individually or together to new districts for training. And so we packaged these 5 modules together in one workshop. And then there was a lot of emphasis placed on follow-up, so project-based mentoring that would continue on after the workshop was delivered. So the workshop happened November 1st through 5th last year. There were 61 attendees and about 11 coordinators from I guess if you include the university institutions, there are about 14 organizations there. There are 3 hospitals in the Cabarole district, and every single one of them sent teams of between 7 and 11 people. All of the Health Center 4s sent teams of at least 5 people, and there are 3 Health Center 4s. And about 10% of the Health Center 3s sent representatives, and then only 3% of the Health Center 2s. And that largely has to do with, we figured that largely had to do with staffing issues. So at a Health Center 2, you've probably got one community health worker or health officer that's working, and it's not easy for someone to leave their post, particularly for 5 days, to come to a workshop. The mix of private and public, 33% private and 66% public, that represents fairly well the mix in the Cabarole district. This is the group of facilitators here, and me standing there on the left. That middle one's almost impossible to see, but it's that's a picture of us looking over some of the birth records in one of the hospitals in the Cabarole district, and then here's a photograph of the workshop with all the participants there. So the principal research question that I had for my thesis was, does the workshop that I've described have the potential to change health outcomes in the Cabarole district? And really, that's a complicated question, and to get at it, you have to think about what it takes to improve a population's health. So the team developed a framework for getting to better health outcomes. So let's start there. And to have improved health outcomes, for example, like a decrease in infant mortality rates would be an example of how you might measure it. You really need to have improved health systems within the district. And there are a number of ways that you can measure improved health systems: access, quality, quantity of health care, and improve cooperation between facilities. But to get to these systems outcomes, you have to improve organizations and how organizations function, so like hospitals, health facilities. And there are a number of ways to measure how well those improve. And but what we were really working on with this workshop we were working with individuals and teams of individuals from these organizations. So what we present here is sort of a cascading effect, a cascade of effects that if we can maybe measure individual health outcomes, then we can show that how these individual outcomes may lead to organizational outcomes, which may then cascade into systems outcomes and ultimately health outcomes. But I'd like to point out the timeline here for making this happen. And the training happened in November 2010, so we're only right here at this point in the process, 3 months out. So we actually don't have data moving forward, but what I'm going to show you is some initial individual level outcome data that may suggest we may get to this point at some time in the future. The methods we used were a series of surveys that measured intent, knowledge, and skills, particularly around management. A series of evaluations that were given to workshop participants around content, relevance, and quality of the materials, and then a series of interviews that happened afterwards to give a more sort of deeper qualitative sort of depth to our data. This is small, and I apologize, but this is basically a comparison of how participants responded to the surveys before the workshop and then after the workshop. And we ran tests to find out whether it looked like these two groups were in fact different, or whether we thought that the two groups were exactly the same. So we're trying to measure some improvement in their management and leadership, confidence, knowledge, and intent to practice before and after the workshop. Did you have a question?
Yes, sir. Aaron, I was wondering if you could talk a little bit about the background of these medical officers that came to the training. Like what makes them a medical officer? What kind of formal or informal training have they had?
Yeah, it varied quite a bit. So there's a rule in the Ministry of Health that in order to manage a hospital, in order to be a medical superintendent, you have to have an advanced degree in management training. So for example, the medical superintendents had been through a 2-year, around a 2-year program in management and leadership. In fact, in Cabarole, 2 of the 3 hospital managers had gone through that training. One of them had a temporary appointment as medical superintendent, but would have to go back and get that additional training if she were to stay in that position. We found the lower level managers, so in charges, very, very few of them had had any management training whatsoever. And I don't remember the exact percentage, but had no sort of very little understanding of maybe even things like how to use a computer and how to keep Excel tables and finances and track the numbers of patients that were coming through. Our workshop was designed for a wide audience. We knew that we couldn't just deliver the workshop to one of those groups and see organizational change, because each organization may have multiple levels of experience in management. So that was part of this content-context divide that I'm talking about. You have to bring in a supervisor and have him help or her help deliver the training course to give the in-charge level the permission to innovate in management within an organization. Does that make sense?
Yeah.
So it was something that was tricky, and I think actually your question gets at. We saw significant differences pre-post for all of these modules, including all the modules combined, except in the instance of corporate governance, which was something that was requested a number of times at the district level to talk about how governance boards influence hospitals and what the role of a governance committee might be in a hospital. But we were delivering a session on corporate governance to a group of hospital and clinic managers who may not then go out and use what they've learned in corporate governance, but it may be good background for them, or really it was good for them to sit through and be part of listening to that alongside their board members. So another, just an example of some of the results we got. This is general participant evaluation of the course itself, the content, relevance, and coverage of each of the modules. This is aggregated together, but you see that it was very highly rated. We didn't actually get even a great spread here. This is poor on this side, and this is excellent. You can see that far and away the workshop was rated very well. So in terms of our expected workshop outcomes, in general, they're very, very positive. Like I said, we did see increased knowledge, improved skills, and intent to practice. We have begun to create collaboration between public and private health facilities in the district. And then as of this last trip, we have seen sustained post-course activities that promote improved organizational function. In fact, we were just back up there last week in the Cabarole District reviewing projects from 8 of the organizations that came back with detailed plans for what they'd like to do to improve the management of their health facilities. And now the group from Kampala, the professors from Kampala, and are working along with the district health office to sort of mentor people through that process and provide a little bit of support that's needed to help improve the facility functioning. There are a number of limitations to the study. If I were to design and carry this through again, I think that there are a number of timing issues that need to be worked out. I showed you the timeline. I think data collection would need to be ongoing, maybe even for a year or up to 3 years. There was no control group, so I think the compared to what question here is really important. If you were to set up something again, you'd do a more robust study. Control groups get a little tricky in health systems research, but there can be ways to approximate control groups in neighboring districts. There's some evidence of selection bias and measurement bias that I think could be at least controlled for in future research. And then there was some design issues, I think, with this study. And if I did it again, I would certainly more carefully collect pre and post identifiers that would allow us to measure individual change. So we could tease out the differences between the way the board members adopted the training that we delivered and like the in-charges, for example. More broadly, the second research question was, has the partnership in general been successful in fulfilling its stated goals over the last year? And so to revisit these, the first one was to improve leadership and management capacity in the health sector. And I think we've had measurable district-level progress. The question now is how to translate this to other districts or translate it to the national level. The second is to improve partnership between the public and faith-based health facilities. And we now have 6 national level organizations cooperating together. We have 8 organizations on the district level cooperating on specific projects. And the medical superintendents of the 3 hospitals are now meeting together for the first time in 5 years, and meeting about how they can better coordinate their services to provide a better coverage for population health outcomes in Cabarole. And then the third partnership goal is to improve the participatory interface, to improve the collaboration between the health sector and local communities. I think this is actually the partnership goal that needs the most work at this point. The only way we've really done that is to include board members on the district level in the training and to deliver training on corporate governance. And then through some of the health management information systems projects that the organizations have chosen, they're giving better feedback to the communities that they're serving in on a regular basis. But I think that one needs a little bit of work. So moving forward, what does this partnership do from here? At a district level, certainly ongoing activities in Cabarole related to mentorship and improved management, and that's currently happening. Our university partners are very keen on a more rigorous evaluation at the district level of what we've done. And then also the medical bureaus are excited about setting district level health targets. So to choose one item like maternal and child health as a district. And then for all the organizations to begin tracking how well they're doing and to try to make incremental improvements on maternal and child health as a district. This is something that in asking people in the Cabarole district or the top level managers, they say is not being done elsewhere in Uganda at this point at all. There's also the question of expanding the project to other districts and in what way we do that without watering down our partnership too much. At a national level in Uganda, we're planning right now to have a big dissemination event in Kampala, probably a day-long activity where we present some of the findings that the partners in Uganda have found through the needs assessment and the literature review. And then we'll also hopefully have a training manual that's published from the workshop we've developed. There's also been talk of developing a national competence framework, which would allow curricular reform across. So Uganda would begin to develop what it considered to be a health manager, and then would have curricula at various institutions that would have to conform to that. There's mixed feelings in the partnership about whether that would be successful or not. And then there's also been some requests to produce a number of case studies in management and leadership in Uganda to just study your top 5 performing hospitals in the nation and top 5 performing districts, see what they're doing right and how others might duplicate some of those successes. So in general, success for the partnership in 3 years really depends on the level of engagement the partners in Uganda would like to have, but in general it involves sustaining some of the progress we've seen at the organizational and the district level, which relates to this framework that I've described, so supporting the transition from individual to organization to systems to health outcomes. And then also increasingly connecting universities to health systems. And this gets at this misalignment. These are all ways to improve the misalignment between health education and national health systems. This is really dark, but I think the essence of it is pretty clear. This is a map of the world at night. And what I actually ran across this just about 2 days ago. This looked at all, this scraped information from published studies and books that had collaborative partners collaborating from different cities around the world. And this isn't just health information or published health work on health. This is all scientific collaborations. But what you can see, you can actually make out the U.S. and you can see that there's a lot of collaborations, for example, that may be happening. I don't know. This may be like Philly and New York, happening between Philly and New York there, and then between other cities around the U.S. You see some collaboration with Mexico City down here. You see a lot of collaboration happening in Europe. But I'd like to point out that Africa is actually right here. And the slide's a little bit dark, so it's hard to see. There are collaborations that are happening between Africa and Europe, and a little bit between Africa and the U.S. But I'd like to point out that there are very few happening, in particular, within the African continent. And I'd like to stake a claim in that if there is going to be improvement in health systems work in Africa and in health in Africa, I think that U.S.-based and European-based institutions need to be involved in creating partnerships within Africa and then figuring out ways to support those partnerships more effectively. So I'd like to say thank you to Meredith in particular and to my family as well. And many thanks to a fantastic team here at the Global Health Institute and at the Divinity School and the Business School, and also this huge number of partners that I worked with in Uganda. I also would like to particularly thank some of the organizational supporters that supported my education and also my research. I'd like to thank the Global Health Institute, and in particular Kim and Sarah, for their ongoing support while I've been here. The World Health Organization, of course, and then the Center for International Studies, and Nancy in particular. If you haven't gotten to know the Center for International Studies, it's one of the gems here at Duke, and you should definitely get to know them while you're here. They have a lot of fantastic seminars and events and a lot of really great support for students and for the international, particular students who are focused on international projects. I'd like to thank the Robertson Foundation and then also the U.S. Department of Education for their support. So, thank you. It took a lot longer than I expected, but we still have plenty of time for questions. While you're thinking about potential questions, this is a word cloud of my thesis, and I think this is the top 60 or maybe 70 words that appear on my thesis, and the words are each sized according to the number of times that they appear. So clearly my thesis is on health. There's a lot of management and leadership. There's a lot of workshops happening in my thesis right here, and then some other funny ones. I think the word et and all both appear in this. So,
Duke's kind of small.
Where's Duke?
Yeah,
Yeah, right there's Duke. Oops. The word Uganda must be in there, but.
Yeah, pretty big.
Oh yeah, okay, that's big. Good. Does anyone have questions? John?
Aaron, I was curious about what's the current regulatory structure in Uganda, particularly in terms of the quality monitoring. Like here we have Joint Commission and medical boards and OSHA and all these, probably people would say is too much regulation. But what's the current system there, and how will they play into this partnership, if there is any?
Yeah, I think that's a good question. I'm not completely familiar with the regulatory mechanisms in Uganda for keeping quality of care high. I don't know, Nixon or Edgar, do you guys have a better sense of that?
So we have the Uganda Medical and Dental Practitioners Council, which kind of regulates the quality of dentists and trained medical doctors. And then we have the Uganda Allied Health Professionals Council, and that's for the lab radiographers and those who don't actually complete the medical degree.
Mm-hmm.
The medical officers we're talking about, they do a 3-year course.
Right.
So they're regulated separately. And then we have the Nurses and Midwives Council.
Huh.
And all of them are under the Ministry of Health.
Got it.
So you kind of coordinate.
And so those are all professional regulatory agencies. Are there quality, like healthcare quality regulatory agencies as well?
Not particularly.
Separate from the Ministry of Health?
Well, it's the Ministry of Health that's in charge of that, but there's no particular body that looks for a particular level.
Yeah, and accredits the hospitals. The Catholic Medical Bureau has a process of accreditation that they've been experimenting with a little bit, and it's positive in its regulatory nature. So they don't close hospitals, but you may be suspended from having accreditation within the Catholic Medical Bureau's system for a while. So I think they're really innovating in that area, and maybe the Ministry of Health may be interested in developing something similar. But the Medical Bureau is leading the way.
I guess I'm curious about as this model of producing more healthcare workers marches along, what's going to oversee the quality side that addresses the access and the cost. But
yeah, I think it's a great question, and I think that gets at so within a partnership like this. So imagine So it's Makerere, UMU, and UCU. So like imagine like Duke, UNC, and NC State being in a partnership together, and then deciding to work on a project and going to like rural eastern North Carolina and delivering a course on what they study. I mean, it's really unusual. And even to get those three universities in the same room together, I mean, they're competitors on one level. And so Makerere, it was clear that they feel that Makerere University feels like, in some sense, they're having to bring the other partners along with them. And they're willing to do that and to improve the health management education systems in the other schools. But I get the distinct feeling that they're okay with that partnership as long as they're on top. And they'll continue to be for a long time, I think. UMU and UC are just developing their programs. But yeah, so I think that speaks for the quality of management education there. It's a good question. Richard?
Just more of a comment. You mentioned that Duke received a MEPI grant to work in Tanzania, and you think that your work will influence how that MEPI grant will develop, or if there will be any collaboration between what Uganda has learned, what your partners in Uganda have learned, and what Duke is trying to do with KCMC in Tanzania?
Yeah, so that was a really exciting development from this past visit to Uganda. John Bartlett, who's the principal investigator on Duke's side of this MEPI grant, came to Kampala. He sat on my committee for my thesis, and then also was involved in some of the meetings we had in Kampala. And he said several times while he was there, we've got an experience. We have funding and have the ability to put leadership and management education into doctors training in Kenya right now, and I think he's going to do that. He asked me in my thesis. He said, "Do you think we should?" And when I came back, generally yes, but with some reservations. He said that there'd certainly be follow-up in figuring out ways to do that. I mean, the fact of the matter is, when you're trained, and you guys who are trained as doctors in Uganda know this better than I do, but many of the health managers that I spoke to in Uganda practiced for a very short period of time as a physician or as a nurse before they were promoted very quickly into management positions. So, which they're not being trained for in medical school. Suddenly they find themselves running a hospital with a staff of 200 people. In fact, one of the better managers that we work with in medical superintendents in Cabarole, he practiced for 6 months out of medical school before he was promoted to head of a hospital, and he's been there for an entirety of his career. So I think it's really important that that's considered in health education, particularly in an African context where you very quickly find yourself as a doctor managing a huge number of people, that you adequately are trained to do that before graduating from medical school. So pre-service education, but it's something that we'll be trying, and hopefully in KCMC.